Greetings and welcome to Treatment Updates for MDS, a telephone and web education program brought to you by the Leukemia and Lymphoma Society. At this time, all participants are in a listen-only mode. If you are participating by telephone and require assistance during the teleconference, please press *0 on your telephone keypad. It is now my pleasure to introduce your moderator, Lizette Figueroa Rivera. Thank you. Lizette, you may begin.
Hello, everyone. On behalf of the Leukemia and Lymphoma Society, I would like to welcome all of you. We have over 700 people participating from across the United States, as well as other participating from other countries, including Afghanistan, Canada, Denmark, Ethiopia, Iraq, the Netherlands, and Singapore. Welcome. With us today, we are fortunate to have Dr. Sekeres to provide us with the latest information on MDS and its current and emerging therapies. LLS is at the forefront of the fight to cure cancer. As the leading source of free blood cancer information, education, and support for patients, survivors, families, and healthcare professionals, LLS helps you navigate you and your loved one's care through treatment, working to ensure that you'll have access to quality, affordable, and coordinated care. Research will help us achieve an end to cancer. In the meantime, patients and caregivers need help before, during, and after a cancer diagnosis and treatment. Please continue to inform us of what you need during this time, and please continue to let us be there for you. Closed captioning is available for this presentation, and the closed captioning button can be found under the video of the speaker. For this program, we would like to acknowledge and thank Bristol Myers Squibb and Taiho Oncology for support of this program. If you're participating today by computer, Dr. Sekeres' slides will display as you see them via video and hear their audio through your computer. You can also print slides from our website at lls.org/programs, or you can download and print the slides from the Materials tab on this program's web platform. Following the presentation, we'll take questions from the audience. I am now pleased to introduce Dr. Sekeres from the Sylvester Comprehensive Cancer Center at the University of Miami in Miami, Florida. Dr. Sekeres, I'm privileged to turn the program over to you.
Thank you so much, Lizette, and what a true privilege it is to be able to talk to you today on behalf of the Leukemia and Lymphoma Society. They're really a marvelous organization, and in my years of doing this, I've always found them to put patients first and your needs first beyond anything else. And I will be talking today about updates in myelodysplastic syndromes, and I'm happy to take questions afterwards. These are my disclosures. So I want to start with a kind of a basic question. What kind of myelodysplastic syndromes do I have? And I'll be abbreviating that MDS during the talk. And what is myelodysplastic syndromes? Well, the World Health Organization classifies myelodysplastic syndromes, just like the World Health Organization has been so involved as we've been thinking about COVID-19 and its variants and its treatments and vaccines to prevent it. So let's start with what myelodysplastic syndromes is. It's a crazy name, isn't it? Myelodysplastic. So that refers to the fact that there are myeloid cells in the bone marrow, and they are dysplastic. They're bad growing. When you look at them under a microscope, they look abnormal. So myelodysplastic actually refers to what a pathologist, a doctor who looks at tissues and cells, is actually seeing under the microscope when examining a bone marrow biopsy or aspirate. Syndromes, we talk about it that way and we give a plural to it because we recognize that one person's MDS may be very, very different from another person's MDS. So it's really a constellation of different subtypes of diagnoses. Now, what's going on in the bone marrow when someone has myelodysplastic syndromes, these abnormal cells, these dysplastic, bad growing cells are growing and growing and growing, and they're taking up more space in the bone marrow. As they take up more space, the normal bone marrow cells start to die out. Now, the normal bone marrow cells are the ones that make the cells in our bloodstreams. They make the red blood cells that bring oxygen to our tissues, and when those are low, we're anemic, the white blood cells that help fight infections, and the platelets that help stop bleeding. So you can imagine as these dysplastic cells are growing and growing and growing in the bone marrow, and the normal cells are dying out, the bone marrow, the factory, isn't able to make the normal cells that wind up in our bloodstream. And that's why often people who have myelodysplastic syndromes come to a doctor's attention because they have anemia, or they have a low platelet count, or a low white blood cell count. Now, the different subtypes of myelodysplastic syndromes that the World Health Organization has defined actually reflect what's going on clinically with a patient and what's going on in that person's bone marrow. For example, one of the categories, the top one, is MDS with single lineage dysplasia. What that means by lineage is one of those three lineages of the blood cells, the reds, the whites, or the platelets. So if somebody has MDS with single lineage dysplasia, it means one of those cell lines is affected by the MDS, meaning that person may have an anemia, or that person may have a low white blood cell count, or a low platelet count, but not two or three of those. Now, this diagnosis comes along with a subtype called MDS with ring sideroblasts. What does that mean? Sounds intriguing. So when a pathologist is looking at cells under a microscope from the bone marrow, that pathologist will put certain dyes onto those cells, and some of those cells will take up a dye and some won't. And that's actually how a pathologist can distinguish among different cells. One type of dye is taken up by the cells and it causes a ring around that cell, just like a ring around Saturn. We call that a ring sideroblast. That becomes important a little bit when we're talking about treatment, because one treatment has been approved by the FDA specifically for people who have ring sideroblasts. Then there's MDS with isolated deletion 5q. Well, that refers to the fact that we all have 23 pairs of chromosomes. They're numbered 1 through 22, and then we have the sex chromosomes, XX for women and XY for men. People who have myelodysplastic syndromes often have an abnormality in one of those chromosomes. That's the genetic material, or the DNA within a cell. Now, most of the time, that isn't something that you would pass down to kids or grandkids. It's not like saying, well, I have this genetic display in my chromosome, and that means that I have blue eyes and you're going to get blue eyes and my grandson's going to have blue eyes. It's something that arose in the bone marrow to cause the MDS. So it's most of the time not something that's passed down to kids or grandkids. In this case, it's MDS that's caused when the leg of chromosome 5 is missing, and that's called deletion 5q. That becomes important because there's another treatment I'll talk about that's specifically for people who have the deletion 5q MDS. Next, we have MDS with multi-lineage dysplasia. So above we talked about single lineage dysplasia. Now we're talking about multi-lineage, meaning that a person will have not just an anemia, but an anemia and a low platelet count, or an anemia and a low white blood cell count. So 2 or more abnormalities, and this can also include ring sideroblasts. The next 2 categories are important. Now we're talking about MDS that has excess blasts. Well, what's a blast? A blast is an immature white blood cell. So full confession here, I have blasts in my bone marrow. I have to if I eventually want mature white blood cells and a mature immune system. So it's normal to have about 1 or 2% blasts in your bone marrow. Once you start to have 5% blasts, we say that that's abnormal, and that would be somebody who has MDS with excess blast type 1 with 5 to 9% blasts. That's too many blasts. It's as if you have these immature cells that are accumulating in your bone marrow, imagine again that this is a factory, and we have a bunch of kindergartners or first graders who are running amok in that factory. Those would be like excess blasts. Blasts are the immature white blood cells. When you have 10 to 19% blasts in the bone marrow, we would say that's MDS with excess blast type 2. And that's getting awfully close to a diagnosis of acute leukemia. We say that somebody has acute leukemia when he or she has 20% blasts in the bone marrow. So one of our goals in treating MDS is to try to prevent it from going into leukemia, particularly in people who start with excess blasts. Okay, so that seems pretty straightforward, right? It should be pretty easy for a pathologist to look at a slide of somebody's bone marrow and check the World Health Organization classification and say, aha, this is what this person has. Well, it turns out it's actually really tricky to evaluate these bone marrows. This was a study we conducted through the National Institutes of Health. Within the NIH is a subdivision called the National Heart, Lung, and Blood Institute. That's the subdivision we conducted this study. And it's a really interesting study that we did. What we did is went to a bunch of centers around the country and said, if you have a patient you suspect has MDS, who hasn't even gotten a diagnosis yet, but you suspect it, please enroll them to this study, and we'll collect information on their history, their quality of life, and we'll actually collect some of their bone marrow samples, and we'll do an analysis at our central labs where we have expert pathologists in MDS to see if they have MDS, and if not, what they have. In the meantime, pathologists who were at the local institution where the person was being seen were also assessing whether or not the person had MDS. And we did a little study where we looked at the agreement between the local pathologist and our expert central pathologist. And it turns out that they agreed 73% of the time. However, they disagreed 27% of the time, meaning that a local pathologist may have said, oh, this person has MDS, and our central pathologist said, no, they don't, they have leukemia, or no, they don't have MDS at all, everything's fine. So the fact that there was disagreement 27% of the time should give you pause. It gave me pause for sure. And what it told me is just how incredibly important it is to get a second opinion on your MDS diagnosis, not only to hear from somebody who specializes in MDS about the best treatment, but also to get a second opinion on the bone marrow biopsy from an expert pathologist, just to make sure it's truly MDS that you have, and if so, what subtype. Okay, so one of the questions my patients often ask me is, what stage is my MDS? And a lot of us have friends or family members who have cancers, and that person may have lung cancer and say, I'm stage 1, or a person may have breast cancer and say, I'm stage 2. So my patients ask me, what stage of MDS do I have? Well, we don't really stage MDS. Instead, what we use is this very complicated system called the International Prognostic Scoring System to classify MDS based on risk. And that's risk of living a long and happy time, or risk of living a short time, and risk of the MDS going into acute leukemia. And we calculate that risk based on all the tests that we run on every patient who has MDS. So we give a point score for the percentage of blasts somebody has in the bone marrow. The more blasts, the higher the score. We give a score based on this, what we call cytogenetics. Those are those chromosome abnormalities in a person's MDS cells, and we've classified those into good risk, chromosome abnormalities, intermediate or poor risk chromosome abnormalities, and we base it on the number of cytopenias a person has. In other words, does a person just have a single anemia, or does that person have an anemia and a low white blood cell count, or maybe all three, anemia, low white blood cell count, and low platelet count? The more of those cytopenias, those low blood counts, the higher the score. We add these numbers up and then place somebody into an IPSS subgroup, and with an estimate of how long that person has to live. Now, I will tell you, this system was published in 1997. It's getting a little bit long in the tooth. And these estimates for survival were only in people who never received a drop of therapy 25 years ago. So we're not sure how accurate the IPSS still is for estimating survival, but it gives us a good sense of whether somebody falls into one of the lower risk groups or one of the higher risk groups. But we recognize that this is a pretty simple way to look at MDS. So we revised the IPSS and published this in 2012. Oh boy, this is getting even more complicated. And now I actually have to have this pasted up in my workroom before I go and see my patients. Now there are a lot more categories for the different sorts of abnormalities that we might find, but they boil down to the same characteristics, whether somebody has very good or good risk chromosomes or poor or very poor risk chromosomes within their MDS cells. Remember, I'm not talking about something that's passed down to family members. Then, and a different score depending on the blast percentage a person has in his or her bone marrow, and the degree of anemia, low platelet count, or low white blood cell count. And then again, we assign a score to that and estimates somebody's prognosis based on it. But again, this was developed in people who never received a drop of therapy, so it's not as accurate once somebody starts to get treated. Okay, but MDS, unfortunately, is even more complicated than that. So I talked about the chromosomes that we have and how people can have chromosome abnormalities with their MDS. Well, every chromosome we have, remember there are 23 pairs of chromosomes, but we have 30,000 genes in our body. So every one of those chromosomes has hundreds to thousands of genes on it. And you could have an abnormality in a single gene that you can miss if you just look at the broad chromosomes. It's like trying to identify one tree in a forest. So we have even more sophisticated technology that's called next generation sequencing, where we'll look for specific gene mutations that we can find on those chromosomes that are commonly associated with myelodysplastic syndromes. And these gene mutations tend to be combinations of letters and numbers and make no sense if you try to just read them. So for example, we know that people who have an NRAS, NRAS, or KRAS mutation tend to have a worse prognosis. On the other hand, people who have an SF3B1 mutation, which is associated with those ring sideroblasts we saw from the WHO classification, actually have a very good prognosis. So this helps us refine even further how we think about prognosis, survival, and even the therapies that we choose. So next question, how should I treat my myelodysplastic syndromes? Well, this is an example of an algorithm that we've developed for how we approach treatment of lower risk MDS. Remember, those folks who have relatively good chromosome abnormalities, relatively low blast percentage, and either 1 or 2 cytopenias, low blood counts. On the left-hand side of this slide, you can see that some of my patients come to see me and have no transfusion needs. They don't require any blood or platelets, and they've got a good quality of life. One of my patients once referred to this as having Myelodysplastic syndrome. He didn't like having to fight the traffic to come in and see me, but other than that, it really didn't affect his life very much. So those are the sorts of folks that I'll just follow, and I'll see them, maybe every month or 2 or even every 6 months. I just saw somebody yesterday whom I see about every 6 months for that person's myelodysplastic syndrome, just to monitor the counts. Then there are people where their predominating problem, the thing that really bugs them, is anemia, a low hemoglobin level. And those are folks in whom we choose certain therapies, or people have a low platelet count, what we call thrombocytopenia, that's really bugging them the most. And then we'll focus on that abnormality. And finally, there are those folks who have multiple abnormalities that are bothering them. Maybe they have an anemia and a low platelet count, and there are different therapies for those. So let's focus on what those therapies are. The first, for anemia, we might consider starting what's called an erythropoiesis stimulating agent, or the drug luspatercept. So what's an erythropoiesis stimulating agent? That sounds like one of those long medical terms we come up with so nobody can figure out what it is. Those are the growth factors that stimulate the growth of a hormone, EPO. They're actually EPO themselves. They're a type of hormone that we give to people, and that EPO stimulates the remaining normal bone marrow cells to make more red blood cells. It can be drugs like erythropoietin or darbepoetin, which are more commonly called things like Procrit, Retacrit, or Aranesp. And a study we did a few years ago showed that people who have lower risk MDS who are treated with one of these growth factors have a chance of responding, in other words, their hemoglobin improving, of about 40%. Now, there's another study that was recently conducted in Europe that showed that that response rate may be as low as 15%, although over time it seemed to improve to 35%. So I will most commonly quote to my patients a chance of getting better with one of these hormones of somewhere around 35 to 40%. And when people get better to it, on average, their hemoglobin improves or they go without transfusions for about a year. Okay, what about luspatercept? This drug was just approved in 2020 for people who have those ring sideroblasts that I mentioned earlier. And in those patients, the response rate, in other words, the number of people who came onto the study requiring red blood cell transfusions and then were able to go at least an 8-week period without needing any red blood cell transfusions was 38%. So if you're thinking about this in simpler ways, about a little over 1/3 of patients benefited from getting the luspatercept. On average, when someone benefited from it, they benefited for about 32 weeks before the drug started to lose its effect. And this is a shot that people get about every 3 weeks, and I think it's a decent option, particularly for those who have ring sideroblasts, which is the on-label indication. Okay, so what if somebody actually has that deletion 5q abnormality I was talking about, or that person has already received an erythropoiesis stimulating agent, that hormone, or luspatercept, and those drugs don't work anymore? Well, then we start to talk about the drug lenalidomide. These are pills, brand name is Revlimid, and in probably the best study looking at people who have the deletion 5q abnormality with MDS, the response rate, the period of time of going without a blood transfusion for at least 8 weeks, was 61%. That's really, really good for the drugs that we look at in lower risk MDS, and that led to the approval of lenalidomide, brand name Revlimid, in Europe. It had already been approved in the United States. Okay, so if I were listening to this and I heard that, I would say, great, but only about 10 to 15% of people with MDS have that deletion 5q abnormality. What about the rest of us? Well, lenalidomide was also explored in people who didn't have the deletion 5q abnormality with lower risk MDS, and the response rate was about 27%. So now we would be talking about 1/4 of people who get better to the drug, and the response duration was very similar to what we saw with that luspatercept earlier at about 32 weeks on average. So I do think this is an option for my patients on label when they have the deletion 5q, and in those patients, the response duration was over 2 years. It works really, really well for those patients. Or off-label for my patients who don't have the deletion 5q abnormality, in whom the response rate, so the percentage of people who get better, and duration were more modest. Okay, what if the predominating problem is a low platelet count with MDS? Well, with lower risk MDS, we would then start to think about what are referred to as thrombopoietin agonists. Oh God, agony, one of those long names again. Think of these as growth factors or hormones, and instead of stimulating the red blood cells, they stimulate the platelets, or the precursors of the platelets in the bone marrow. And there are 2 major brands of this that are available in the United States. One is referred to as Romiplastim, or the brand name is Nplate. The other is Eltrombopag, the brand name is Promacta. Now, these are not approved specifically for MDS. They're approved for a condition in which the immune system attacks the platelets, something called ITP, or idiopathic thrombocytopenic purpura. However, they can be used off-label for the treatment of low platelet counts associated with myelodysplastic syndromes, because there are a couple of studies that support that use. This is one of those studies. In this study, about 40% of patients who were treated with Romiplastim got better. In other words, their platelet count improved to the drug compared to those folks who got placebo. And on this slide, this is how complicated this gets. Success was defined as an improvement in CSBE, clinically significant bleeding events. In other words, did somebody have kind of a major bleed, not just, my gums were bleeding a little bit after I brushed my teeth, but they had like a bad nosebleed or blood from their GI tract. And it turns out that those who received the drug ramiprostame, the brand name Nplate, those clinically significant bleeding events occurred in about 80 times compared to 226 times for those patients who didn't receive the drug. So that was an improvement. Also, those who got the drug, when you focus on PTEs, platelet transfusion events, how often did they need to receive a transfusion of platelets? That occurred much less frequently for those who got ramiprostame versus those who received placebo. So I do think this is an acceptable off-label use of one of these drugs. The caution I will give you, however, is that these drugs should never, never, never be given to folks who have MDS with excess blasts. It turns out that blasts have receptors on them that this hormone can trigger. So people can have an increase in blast percentages if they receive the ramiprostame, brand name Nplate, or the eltrombopag, brand name Promacta. So we stay away from these drugs in people who have excess blasts. Okay, what about folks who have multiple cytopenias? In other words, they'll have anemia and a low white blood cell count, or anemia and a low platelet count. Well, then we think about a couple of different types of treatments we can use. The first are drugs that are referred to as HMAs, hypomethylating agents. So this includes drugs I'm going to talk a little bit more about in a second that include azacitidine, brand name Vidasa, decitabine, brand name Dacogen, or there's a new pill version of decitabine that's a combination of decitabine and cedazuridine. Now, we did a study looking at using these drugs not in patients with higher risk MDS, but in lower risk MDS, and giving these drugs for a shorter period of time. You can imagine this is a study that we conducted without any support from a pharmaceutical company, because what drug company in their right mind would want to fund a study showing that giving less of their drug is actually better? But what we found is that in patients who have lower risk MDS, less is more. We found that those who received only 3 days of the Vidasa instead of the product label 7 days, or 3 days of the decitabine brand name Dacogen, where ordinarily we would give it for 5 days, had an overall response rate, here I'm highlighting it, at 59%. Typically, we would have expected an overall response rate of only 35%. So this was much better, and it lasted for longer, for about a year and a half. So my standard approach to treating somebody with lower risk MDS who has more than one blood count abnormality is to use 3 days of azacitidine, brand name Vidasa, or 3 days of decitabine, brand name Dacogen. One other approach we can take is to actually combat the immune system. There's a theory in MDS that some MDS subtypes actually arise because the immune system by accident attacks the bone marrow cells. And if we can stop the immune system from doing that, the bone marrow cells will actually start to flourish and produce the normal blood cells that they should. So there are a couple of studies that have used a drug called ATG, anti-thymocyte globulin, that basically stops the immune system in its tracks and stops the immune system from attacking the bone marrow. In both of these studies, the ATG works about 1/3 of the time. The top study was conducted in the US, the bottom study was conducted in Europe. And the duration of response was about a year to a year and a half. The bad news is you have to go into the hospital to get 4 days of the ATG because people can have bad allergic reactions to it. The good news is it's kind of one and done. You go into the hospital for 4 days, and then you take a pill, a low-dose cyclosporin, which also helps suppress the immune system, and you've basically taken care of it for a while. So it works 1/3 of the time. I do reserve this for my patients who have multiple cytopenias, so a bunch of blood counts that are low, and who have already received a hypomethylating agent, the azacitidine or decitabine, and it hasn't worked for them or it's stopped working. Okay, so let's switch to people who have higher risk MDS. This is, again, one of those treatment algorithms that actually we wrote 8 years ago, but it hasn't changed very much. So for people with higher risk MDS, we'll often talk very early about whether or not they would benefit from a bone marrow transplant, where we give drugs to eliminate bone marrow cells from the bone marrow and then replace those cells with a transfusion of somebody else's healthy bone marrow. that healthy bone marrow then takes up residence in the bones and starts to hopefully produce normal, healthy blood cells. So one approach we take is to talk about bone marrow transplant from the very beginning of somebody's diagnosis. And while we're doing that, we will start to treat them with hypomethylating agents. As I mentioned before, there are 3 of them, and I'm going to talk about them right now. The first drug is called azacitidine, brand name Vidasa. And in this study, patients were randomized to receive the azacitidine or conventional care regimens. Now, conventional care regimens, 60% of them consisted of people receiving best supportive care, so just transfusions or antibiotics as they needed them, but no active therapy for their MDS, or they received chemotherapy as if they had acute leukemia and were being treated for that. And in this study, people who received the azacitidine, brand name Vidasa, lived an average of 2 years compared to 15 months for those who received the conventional care regimens. And this was a significant difference. This was a really big deal because it was the first study that showed a survival advantage for any drug that we use to treat MDS compared to anything else. Now, I will tell you, over time, we have found the survival to drugs like azacitidine or decitabine to be more modest than that 24 months. Still, I am very comfortable in saying that treatment with azacitidine or decitabine is beneficial to my patients, and with the azacitidine, it can prolong their lives. Now, the second drug I'm going to discuss is the decitabine that I mentioned. This was also looked at in a trial in which people with higher risk MDS were randomized to receive decitabine or best supportive care. Now, in this study, for very strange reasons, there was no survival advantage for those who received decitabine versus those who received best supportive care. In other words, transfusions, antibiotics, but no active therapy for their MDS. But there are a bunch of us in the MDS community who believe that this was a flawed study. The decitabine was given in the wrong dose, the wrong way, and the wrong regimen. And the patients enrolled to this study were very different than the ones enrolled to the azacitidine study. So follow-up studies have compared decitabine to azacitidine in population registries and have found absolutely no difference between the two in terms of how long somebody lives. So we feel pretty comfortable in the interchange between decitabine and azacitidine. So if you're on decitabine, brand name Dacogen, don't worry. We think it works just as well as the azacitidine, brand name Vidasa. I will tell you that my personal practice is to treat people with the azacitidine, brand name Vidasa, because of the previous slide I showed with the survival advantage, and because I think they tolerate it a little bit better. Now, I told you there was a third kid on the block now, and that's a pill form of decitabine combined with something called cedazuridine, and that cedazuridine actually prevents the decitabine from being broken down in the stomach's acid. So it's a way that it can be given in pill form. What we see from this study when we look at the various definitions of response here, those patients who received the oral version of the decitabine seem to have about the same response rate as if they had received the IV decitabine. So the pills seem to work about as well as the IV. We don't have any head-to-head comparison because this was actually enough data to convince the FDA to approve the decitabine in a pill form. Now, I mentioned transplant to you earlier, and I'm showing something that's called a survival curve. So if you look at it, it starts out at 1.0. That means 100% of people are alive when the study was started. And then on the bottom axis of the graph, you'll see is time denoted in months. So 20 months, 40 months, 60 months, 80 months, 100 months. When you look at a survival curve like this, you always want to be on the top curve. That means people are living longer when they receive a certain treatment. Now, for lower risk MDS, for people who have lower risk MDS, we don't talk about transplant up front because guess what? That top line, that yellow curve, represents people who receive drug therapy and not a transplant. The bottom line are those people who received a transplant. So people live longer if they don't receive a bone marrow transplant at diagnosis with lower risk MDS, we usually reserve transplant for this group after they've been treated with all the therapies I've just mentioned. The therapies may have worked for a while and then stop working, and my patients cycle through it, and they're left with few other options. At that point, that's when transplant is really ideal for my patients with lower risk MDS. For higher risk MDS, the story is different and a little more confusing. Once again, that line you're seeing that's yellow are people who did not receive a transplant. The blue line are people who did receive a transplant. And you'll see that eventually the blue line is higher than the yellow line, meaning those who received a transplant live longer than those who don't. But it takes a little while for that blue line to eventually triumph because there are side effects to getting a transplant. And some of those side effects include people dying from the transplant itself. So I do talk about transplant at diagnosis for my patients with higher risk MDS and ask them to consider it, and I refer them to a transplanter. I myself don't do bone marrow transplants. So when I refer someone to a transplant, it's with a pure heart. Because I do think eventually there's a chance that people will live longer, and in fact, transplant is the only cure for MDS. So if I have a patient who wants to be very aggressive about his or her MDS, and is willing to go through pretty aggressive therapy, then I will 100% support them in pursuing a transplant. Okay, what can I do to maximize the chance that treatment will work? Well, my top message with this is that most side effects are manageable. Most side effects to these drugs, we can find a way to make them tolerable or eliminate them. So I beg you to ask your healthcare team to manage them. This isn't something that you should have to figure out on your own. I have some patients who get an injection of the azacitidine, the Vidaza, underneath their skin, and they get terrible rashes from it, and it burns, and they don't like it. Well, then we can switch to the injections to giving them intravenously. The drug works just as well, and it's much more tolerable. Or we can start to prescribe medicines to help with nausea or medicines to help with constipation to get folks through it. I have some patients who get constipated when they get treated with, for example, the azacitidine, and they drink a lot of fluids the weekend before they start, and they're fine. So sometimes we can find pretty easy and palatable solutions to help manage this. Drugs take a while to work. So whenever you start a drug, plan on taking 4 to 6 months to see whether or not it works. Stopping after 1 or 2 courses of therapy, you may have, I say you, but really not you, your doctor may have shot you in the foot. Because these drugs, remember, MDS takes a while to arise. It's going to take a while to get rid of as well. So I always have a contract with my patients about staying on a drug for 4 to 6 months before we declare victory or defeat. Don't start and stop MDS medications. That's how MDS becomes resistant to drugs. So once you start on it, keep going. And this is a marathon, not a race, particularly with lower risk MDS. Remember, most of the drugs I showed you work about 1/4 to 1/3 of the time. That means that we're going to have to try 3 or 4 drugs before we find one that works. So we cycle through them, and we'll go on that walk right along with you. So I want to thank all of you for listening. I'm so happy with my move from snowy Cleveland to sunny Miami, and I will be the first to admit that is a very unfair picture of Cleveland, but it shows the dramatic effect. And I'm happy to take questions at the end of this, and we'll hand it back to Lizette.
Thank you so much, Dr. Sekeres. Thank you for the presentation. And as Dr. Sekeres mentioned, it's now time for the question and answer portion of our program. For everyone's benefit, if you can please keep your questions general in nature without many personal details, so the doctor can provide answers that are general in nature. Operator, can you please give instructions to our telephone and web audiences?
To participate in the Q&A session by phone, please press star and 1 on your telephone keypad. If you are joining us by web, simply click on Ask a Question, type your question, and then hit Submit. We will take questions in the order they are received, and we can only take 1 question per person. Once a phone question has been voiced, I will transfer you back into the listening audience. Again, to ask a question, please dial star and 1 on your telephone keypad, or click on Ask a Question, type your question, and then submit.
Thank you so much. And we'll start with the web audience. Dr. Amy asks, what levels of dysplasia is considered MDS and not de novo AML?
Oh, that's a great question. So by definition, myelodysplastic syndrome, percent dysplasia in one cell line. So in other words, in the bone marrow, 10% of the primordial red blood cells have to be dysplastic, or 10% of the primordial white blood cells, or 10% of the early platelets. There's no distinction with acute myeloid leukemia, and in fact, there is a WHO category for acute myeloid leukemia with a background of dysplasia. So the dysplasia itself doesn't distinguish myelodysplastic syndrome from leukemia. It's the blast percentage. And remember, 19% blasts or lower is MDS, 20% blasts or higher is acute myeloid leukemia.
Thank you. And along that line, Sarah is asking, what's the difference between MDS and MPNs, which are myeloproliferative neoplasms?
Another fabulous question. You know, they're on a continuum, and there's a WHO category that's MDS/MPN overlap for people who have some component of their bone marrow that has myelodysplastic syndrome, and the other component that has myeloproliferative neoplasms. In general, what I would say is that myelodysplastic syndrome, by definition, has to have that dysplasia, that dysplastic component. Myeloproliferative neoplasms don't. They involve cells that are growing very quickly. They're proliferating. So when we look at the cellularity in a bone marrow, it's often elevated for somebody who has myelodysplastic syndrome because these dysplastic cells are growing a lot. So maybe in a 70-year-old, I should see about 30% cellularity. We say it's roughly 100 minus a person's age. So I should see 30% cells in a microscope view. With MDS, I might see 60% cells. With a myeloproliferative neoplasm, I'll often see 90% cells. So it's cell growth, cell proliferating, as opposed to cell dysplasia, bad growth.
Thank you. And we'll take the next question from the telephone audience, please.
We'll hear from Karen in New York. Please go ahead.
Thank you, Doctor. Just a quick question. In your knowledge, my husband was on Zario and Procrit for 2.5 years, was diagnosed with congestive heart failure after receiving the COVID vaccines. Since then, none of the medicines that have been tried are able to raise his hemo. Is there any correlation that you know of between heart meds and medicines for MDS? Thank you.
Boy, that is another fabulous question. Heart medicines themselves shouldn't affect MDS. So it shouldn't cause MDS, or it shouldn't make MDS worse. What there may be, remember I showed those genetic mutations where we look at the specific genes that are abnormal in MDS that are on the chromosomes. Remember, the chromosomes have a total of 30,000 genes across 23 pairs. So we look for these very specific gene mutations that we find in myelodysplastic syndrome. There was a study that was done a few years ago that showed that people who don't even have a diagnosis of myelodysplastic syndrome, but have some of these mutations, are more likely to develop myelodysplastic syndrome, but surprisingly, we're more likely to develop heart disease. And in fact, having one of these mutations is more of a risk factor for developing heart disease than a high cholesterol level. So we discovered that there is this link between heart disease and myelodysplastic syndrome, probably because of the inflammation around heart disease. And there's an argument that there's a similar inflammation around myelodysplastic syndromes, and they're both caused by one of these gene mutations. So I wonder if in this case, and kind of broadening it to the whole audience, it's not surprising to hear similar diagnosis, the same person having heart disease and myelodysplastic syndrome, because we think there may be a common cause to it, but heart disease medicines don't cause myelodysplastic syndromes. One thing I have found with heart medicines in my patients is that they can cause a fatigue. So it's very hard for me to distinguish in my patients, is fatigue due to some degree of anemia, or is it due to heart medicines that somebody's on?
Well, thank you for that question. Since you mentioned fatigue, Doctor, Linda is asking how to deal with fatigue as well as loss of appetite.
Boy, that's a good one. So both of those things can arise from anemia. So the best answer to that is to get blood transfusions if you need them and try to find a therapy that works. Easy for me to say, right? But it means cycling through therapies. If you're on a drug like one of the erythropoiesis stimulating agents, that remember that erythropoietin or darbepoetin, those hormone shots, and sometimes healthcare providers can't think of a next option, so they just keep you on the same drug long term. And I've had patients who are on those drugs for like 5 years, 6 years, and they're getting a blood transfusion every month. Well, the drug's not working. So one approach to that is if you have persistent anemia and it's causing things like fatigue and a low appetite, stop the drug and go on to another drug. And if your doctor can't come up with an option for what another drug might be, go get a second opinion, to be honest. Now, that may be oversimplifying things. Some of my patients can also have fatigue from just having myelodysplastic syndrome itself. There's this whole theory that the myelodysplastic cells release chemicals that also cause normal bone marrow cells to die off, but also can make you feel not so good. Then that can include fatigue and not wanting to eat very much. So once again, the answer to that is to treat the myelodysplastic syndrome, try to reduce it more so that they're not producing these chemicals that lead to these symptoms. Finally, what I would say is, I'm a huge fan of consulting nutritionists or dietitians for thinking about diet. One thing my patients will sometimes tell me is that when they're getting treated with some of the drugs I use, like the azocytogene, their sense of taste changes. And not in a way they can really put their finger on. The best I can come up with is that my patients who get drugs like that, where their sense of taste changes, it's almost like toddlers. You know how toddlers want foods based on texture more than on taste? My patients get very sensitive to texture of foods. And for example, I have patients who will binge on, they always talk about moist foods or wet foods like melons. I had one patient who loved lo mein because of the greasy noodles. He loved the texture of it. So going to a nutritionist or a dietitian can help with food choice. And I'll throw in that nugget also, that your sense of taste may change and experiment with different types of food.
Thank you so much. And I know that you did mention the EPOs. Ron is asking if they can possibly cause secondary myelofibrosis.
Oh, that is a fabulous question. So let me back up a little bit. By EPOs, we're talking about those erythropoiesis stimulating agents. We have all sorts of different abbreviations for them. So I abbreviate them ESAs, but EPO is fine because it's short for erythropoietin or darbepoetin. The brand names, remember, are going to be things like Procrit, Retacrit, or Aranesp. And these are hormones, like I said, that stimulate the remaining normal bone marrow cells to work better, to produce more normal cells. I haven't seen much on them causing myelofibrosis. It is possible that you may have started out with a myelodysplastic syndrome. And remember how I said earlier there can be an overlap diagnosis, myelodysplastic syndrome, and then a myeloproliferative neoplasm, an MDS-MPN category. It's actually defined by the World Health Organization. Part of MPN, I talked earlier about a bone marrow that had 90% cells in it. You can also develop fibrosis with it. So it may be that what you have is an MDS that's now evolving into an overlap disorder where there's also the fibrosis. There is a story not about EPO causing fibrosis, but about TPO, those thrombopoietin drugs I mentioned earlier, the one that stimulate platelet growth. And that story is in patients who have the autoimmune disorder where they chew up their own platelets, that ITP, idiopathic thrombocytopenic purpura. And in those patients who are treated with the drugs like eltrombopag or romiplastim, the Promacta or Nplate, there is a story about myelofibrosis occurring. So not with the EPO drugs, but with the TPO drugs, the thrombopoietin agonists, the romiplastim and eltrombopag.
Thank you so much. And we'll take the next question from our telephone audience, please.
We'll hear from Irene in Utah. Please go ahead. Your line is open.
Hi, doctor. Thank you for taking my call. I'm an 80-year-old person, and I have had 5Q minus since I've turned 62, which they said was very young to have myelodysplastic syndrome. And I have been on Revlimid all these years, which was wonderful, up to about 6 months ago. And I've had problems with my blood cells dropping. My neutrophils are very low. I've had 3 units of blood since January. And I wondered what I had taken a drug called Inclovi. I don't know if you know anything about that, but it seemed to lower my cells. And I wondered if you could tell me something about this.
Sure. Let me start out with congratulating you on having such phenomenal success with the lenalidomide brand name Revlimid. If I'm doing my math right, you've been on it for 18 years. It's 2022. That takes us back to 2004, which means I think you may have gotten it before it was even FDA approved, because it wasn't approved in 2004, which is amazing. So that's just incredible. But it's not curative, as you're pointing out. So at a certain point, the lenalidomide or Revlimid will stop working. So depending on your blood count abnormalities, you can go on one of the hypomethylating agents. Inclovi is the brand name for that pill, the decitabine and the cetirizine. So I think that's a perfectly reasonable option to try after being treated with the lenalidomide or the Revlimid. I would use it more for people who have more than one cell line that's affected, so not just anemia, but anemia and a low platelet count, or anemia and a low white blood cell count. Another thing to consider, if it is just an isolated anemia that you have, is to think about the luspatercept. That may be used off-label. You'd have to look into that depending on whether or not you have ring sideroblasts. But yes, eventually all of these drugs will stop working, and then we start the cycle. We start to go through other drugs and see if we can find another one that works just as well. And that's what it sounds like that's what you're doing.
Thank you so much for the question. And we have a few questions, Doctor, in regards to transplant. Warren is asking, is stem cell transplant and bone marrow transplant the same? And we do have folks asking if MDS would come back after transplant.
Yeah, both great questions. So colloquially, kind of informally, we will interchange bone marrow transplant and stem cell transplant, and it really means the same thing. It's getting cells from another person's bone marrow and then collecting them, cleaning them, and transfusing them into another person, and hoping that they will then set up residence in the bone marrow and start to make normal blood cells again. Technically, stem cells, when you're collecting bone marrow cells from another person, you can do it one of two ways. You can either do something like a bone marrow biopsy in that person, but instead of one bone marrow biopsy, you're doing about 40 bone marrow biopsies to collect enough of those cells. So that's often done under anesthesia. Or you can give a person drugs to cause that person to send bone marrow cells out into the bloodstream, and then the bloodstream is pheresed. It's basically collected from the bloodstream itself without a bone marrow biopsy. But it's the same cells. They're either way, they're from the bone marrow itself. So that's the distinction between the two. In terms of MDS coming back after a bone marrow transplant, yes, that is possible. The bone marrow transplant may fail. So there are a lot of different percentages that are quoted to people about the chance that a bone marrow transplant will work, the chance that the MDS will come back, the chance that a person will suffer harm from the transplant or even die. Most commonly, I've seen numbers that are around 40 to 50% chance that the bone marrow transplant will work, 20% chance that somebody will suffer significant harm or even death. And that puts us at about 30 to 40% chance that the MDS will actually come back and the transplant was not successful.
Thank you, Doctor. We have a question from Nadine. Nadine is asking, can you please discuss targeted personalized CAR T cell therapy for MDS? And also, where are we with CRISPR gene editing for MDS?
Yeah, well, I can tell that you must do a lot of reading because that's pretty sophisticated stuff. Those are both still in a research phase with MDS. We are not even close to having those as part of our standard therapies yet. CAR Ts are really fascinating. Imagine a person who has a type of cancer, and let's say it's leukemia. And that person has active leukemia, it hasn't gone into remission, it's flowing in their bloodstream, and then you take some of those leukemia cells out of the person's bloodstream along with some of that person's white blood cells, and you put them outside of the body into like a test tube, and you grow the white blood cells, particularly those that seem to form around those leukemia cells, and get rid of them. Because remember, eventually, if prompted the right way, our immune system has the potential of getting rid of cancer. So you're prompting the immune system, the part of the immune system that can configure to that cancer to grow. So you have like instead of a couple of soldiers, an army of those white blood cells configured specifically for that cancer, and then you reinfuse them into a person's body, and you say, okay, go get rid of what's there. And so it's pretty remarkable technology. And it has been successful in people who have lymphomas and in people who have acute lymphoblastic leukemia. So notice that lymph that I keep mentioning. We talked about myelodysplastic syndrome and the myeloid cells in the bone marrow. That represents, let's say, half the cells in the bone marrow. The other half of the white blood cells are lymphoma cells, lymphoid cells. So CAR T really works for lymphoid cells, lymphoma cells. It doesn't work for myeloid cells. So you can find CAR T studies that will enroll people who have acute myeloid leukemia or myelodysplastic syndromes, but unfortunately, they really haven't worked well. CRISPR technology is where we take a cell, we alter the genetics in the cell, we fix the mutations, the things that are wrong, and then we put that into a virus and reinfect a person with it, and you get that fixed DNA now incorporated into a person's cells and hopefully get rid of certain conditions. It has worked with things like sickle cell anemia. It has worked with very rare genetic disorders where there's a single abnormality that's caused the disorder. With myelodysplastic syndrome, I think it has potential, but it's going to be hard because myelodysplastic syndrome isn't a single genetic abnormality that caused the myelodysplastic syndrome. It's often 3 or 4 abnormalities that have caused it.
Thank you. And our last question today is from Lorraine. Is there research targeting the specific genetic mutations in MDS? And I'm also interested in Doctor, what you're excited about with the recent research in MDS.
Yeah, great question. There are a couple of drugs that are approved for the treatment of acute myeloid leukemia that target something called an IDH abnormality. Remember those mutations I said were a bunch of letters and numbers. So there are 2 mutations, one that's called IDH1 and another called IDH2. And there are 2 drugs already approved by the FDA for people who have leukemia with these mutations. Well, it turns out these drugs also work in people with myelodysplastic syndrome who have these mutations. So I will use these drugs off-label in my patients with MDS who have one of these mutations. I'll often save it for after I've tried a hypomethylating agent like azocytogene or D-cytabine in them, and that drug has stopped working. Then I'll use one of the IDH inhibitors. So I'm very excited about that, and I remain excited about combinations of drugs and their potential for working in people who have higher risk MDS. So azocytogene or D-cytabine plus something else, and there are a number of trials looking at these sorts of combinations right now, including combined with the drug venetoclax or combined with the drug sabatolimab or with another drug called magrolimab.
Great. It's really great to know that so much is happening in the MDS space, in different treatments for MDS, newer combinations, and hopefully newer treatments that have a a better quality of life associated with them, right, Doctor? Less side effects.
Yep, absolutely.
Great. Well, thank you so much, Lorraine. That was our final question today. And thank you so much, Dr. Sekeres, for volunteering your time and expertise with us today, especially during these busy times. And for folks that are on the line, if we weren't able to get your question answered today, or you want more information, you may speak to an LLS information specialist at 1-800-955-4572. We're there from 9 a.m. to 9 p.m. Eastern Time, or you can reach us by email at lls.org/contact us. Information specialists are available to answer your questions about treatment, including clinical trials, and answer other questions you may have about support, including financial assistance for treatment. We also have a clinical trial support center where clinical trial nurse navigators are nurses with expertise in blood cancers, and they can assist you with finding out if a clinical trial is right for you. And they could be found at lls.org/navigation. And as Dr. Sekeres mentioned the importance of nutrition, LLS does have free nutrition consults to assist patients and caregivers. You can visit lls.org/nutrition for more information. Webcast participants, please complete the program evaluation now as it pops up on your screen. Phone participants can complete the evaluation at www.lls.org/eval. That's lls.org/EVAL, or complete the form included in your mailed packet. For the professionals on this call, please note that there are no continuing education credits offered for this program. As a reminder, you can download and print the slides, as well as listen to the audio and view the program on our website, lls.org/programs. Again, we would like to acknowledge and thank Bristol Myers Squibb and Taiho Oncology for their support of this program. Again, Dr. Sekeres, thank you so much for volunteering your time with us today. And on behalf of the Leukemia and Lymphoma Society, thank you all for joining us. Goodbye, and we wish you well.